Hi, my name is Terry Kuti. I am the founder and director of Deep Sea Foundation. Welcome to our educational channel where we talk about topics related to breast cancer and breast reconstruction. And my guest today is Dr. Christopher Pannucci, who practices out of Spokane, Washington at Plastic Surgery Northwest. Dr. Pannucci is a plastic surgeon board certified by the American Board of Plastic Surgery and is a fellowship-trained microvascular reconstructive surgeon. His clinical interests include breast reconstruction surgery, general reconstructive surgery, and aesthetic surgery. He offers a full range of reconstructive techniques, including microsurgical free tissue transfer and perforator flaps like DEEP flap, the free flap using the patient's own tummy tissue. Dr. Pannucci is an experienced microvascular surgeon and has performed hundreds of free flap procedures. He is also an accomplished surgeon, educator, and sought-after speaker for national meetings in plastic and microvascular surgery. Dr. Pannucci is a member of the American Society of Plastic Surgeons, the Washington Society of Plastic Surgeons, and the Northwest Society of Plastic Surgeons. He has taken a keen interest and is nationally recognized and advocates for patient safety, particularly in the realm of venous thromboembolism, known as VTE. And VTE is our focus of discussion today. We would like to present the listeners, the patients, and give them the language and terminology needed so that they can have an informed conversation with their microvascular surgeon for their breast reconstruction. So, Dr. Pannucci, I'm very glad to have you on the program today to talk about this important topic and waving at you across the state of Washington.
Well, and hello, and waving back. It's lovely to be here. I'm going to go ahead and share my screen. And while we are doing that, first of all, thank you for having me, because
Absolutely.
it is wonderful to be here, and it's wonderful to have the opportunity to educate on this super important patient safety issue. And actually, this month, we're recording this in early March. March is actually Blood Clot Awareness Month, so
Yes.
uniquely time appropriate for this topic.
Yep.
So today, I want to provide a patient-facing discussion for risk for blood clots, deep vein thrombosis, and pulmonary embolus in breast reconstruction. This is not a topic that I am new to. It's something that I had a more than 15-year interest and research trajectory in. As a complement to all of Terry's work at the Deep Sea Foundation, I talk about breast reconstruction a ton on my own personal Instagram page there on your left, and also talk specifically about blood clots and risk reduction and a lot of the things that we're going to be talking about today on my blood clot-centric page, which is DVT prevention. I think it's important to recognize I have disclosures. You may or may not find them relevant, but I certainly want everyone watching to understand that I have worked with implant companies for research and also for education in the past. Specifically, Mentor, an implant company. I currently have one finished and one active grant from them, providing direct research support only to look at blunt traumatic injury in women with breast implants. And stay tuned for those data. Should be a few months before they come out, but they will be uniquely interesting. Mm-hmm. Also, Sientra, an implant company, did have me give a surgeon-facing version of this talk at one of their national meetings last year. I do sit on the editorial board of the Aesthetic Surgery Journal, and I do consulting work in venous thromboembolism. And that is both practice consulting, helping surgeons in their practice to optimize their prevention strategies, and also legal work if asked to provide input on was care appropriate or not. I think it's important, especially in a patient-facing discussion, to define what exactly are we talking about. And deep vein thrombosis, or DVT, is a blood clot that occurs in the deep veins. This blood clot is not normal. Normally, within the lumen of the vein, you have a straight flow of blood. And a deep vein thrombosis is when, instead of being filled with blood, all or part of that blood vessel, lumen or inside, is filled with clots. As you can see in this picture, these clots will often occur near the venous valves, which are designed to prevent backflow of that blood. But by definition, a clot within the lumen of the vein is abnormal. Now, I want you to understand as listeners, what do these veins look like? These are actually thigh-based veins. This picture was taken when I was raising a thigh-based free flap, but these are deep veins, veins that are in between two named muscles. These veins, you see that penny for reference, are in this case about 2 to 3 millimeters in size. They certainly can be larger than that as you get into the thigh and into the abdomen. And these veins, this is actually the view that we as microvascular surgeons see when dissecting the deep flap. You can see on the screen left that you have vein with an artery in between, and that sort of triad is very consistent in the body. This is exactly what we see when we're dissecting a deep flap as well. Now, pulmonary embolus is when these deep vein thromboses actually break off and are pushed with the flow of blood. All veins, as they coalesce, will eventually lead to the heart, and a pulmonary embolus is where that clot that originated in the veins passes through the heart and into the pulmonary artery. Now, eventually, that clot will get pushed with the flow of blood and lodge somewhere in the lungs as the vessels get smaller and smaller. A saddle pulmonary embolus, which fortunately is rare, is when a clot is large enough that it actually sticks at that main split between the right and left pulmonary artery. This means that the heart is now pumping not against an open blood vessel, but against a solid wall of clot. This is the worst case scenario where the heart will actually pump until it cannot pump anymore, and the blood cannot get to the lungs to get oxygen. So this is the worst case scenario of venous thromboembolism because it can result in death. What do these clots look like? Well, these are autopsy photos that I got from the internet. And on your left is a saddle embolus. You can see that there's a large clot burden right at that main junction. You can see the pulmonary arteries going right and left. And then on the right is a vein actually opened up so you can see the inside and the clot within.
Mm.
Now, I don't want anyone to be super discouraged here. I want to be very clear. This is a rare event. It is also an important event, which is why I spend so much time talking about it and educating and helping you to understand. By rare, I think it's important to understand what the numbers are like. So Arash Momeni is a friend of mine, is on faculty at Stanford, and is in his own right a very established venous thromboembolism researcher. He published this paper which looked at 4 different states across the country and its registry data, but it's got data from more than 50,000 women who had surgical treatment for breast cancer. Really helps to establish that the expected rate of these blood clots in breast cancer patients is less than 1%, 0.8% at 90 days. Not just understanding what the risk is, but they went farther to look at risk factors, and they actually showed that the people that get clots, they are more likely to have a personal or family history of clots. They're more likely to be hospitalized after surgery, and especially hospitalized for a longer duration of time. And possibly because of the increased operating room time, which we'll talk about, or the plication, which we'll talk about, patients who have autologous reconstruction, like tummy-based reconstruction, are more likely to have clots than those who have expanders or implants. They also looked at when, and this was interesting, that not all clots happen during your initial hospitalization. Certainly some do, about a third do while you're in the hospital that first time. Risk for clots, in my own research experience, tends to peak between weeks 2 and 3, but can remain elevated on a more long-term basis. But these data show that even in that first 1, 2, 3 weeks, the majority of those clots are starting to happen. Another paper out of Canada, again, looking at breast cancer surgical patients, looking at risk for clots. And they showed, again, that autologous reconstruction with your own tissue, puts you at higher risk than an implant-based reconstruction, no reconstruction. Also, those at elevated body mass index, so heavier folks, are going to be at higher risk. So I think that helps the listeners to understand who is at higher risk for this problem. Now flip that, right? Not the patient, but the surgeon focus. These are data that are probably 13 or 14 years old at this point, but some of my collaborators and I actually surveyed the American Society of Plastic Surgery membership, and we said, listen, amongst you surgeons that do breast reconstruction, have you personally had a patient who's had a clot? And somewhere between a quarter and a third of surgeons said, yes, I have. Okay. What was maybe even more concerning was that amongst surgeons, 1 in 20 surgeons who performs, 1 in 25 actually surgeons who performs breast reconstruction has personally had a patient die from this complication.
Mm.
So when you think
That's-
of the surgeon experience of taking care of thousands of patients over a career,
Yeah.
many surgeons, not many, 1 in 25 surgeons have actually had a patient not only have a clot, but have a life-ending clot.
Devastating to the surgeon and the family. Yeah.
I agree. I agree. Fortunately, most clots are rare, and most clots are not fatal, but clots do have other ramifications. So at the least, if you have a clot, you end up getting 3 to 6 months of anticoagulation.
Mm-hmm.
You also, we also know that patients with symptomatic blood clots, 1 in 10 can develop something called a post-thrombotic syndrome.
Okay.
We showed that image earlier of venous valves, which prevent backflow of blood.
Mm-hmm.
The inflammation around a clot can injure those valves and create a situation where blood flows backwards or in the legs down into the legs. And this can produce this clinical situation of these chronic ulcers that are really challenging to treat, and it's known to negatively impact quality of life. So when we talk about means for prevention, we're not only talking about blood clots and the potential for them to be fatal, but also things like this, the post-thrombotic syndrome. As we talked about pulmonary emboli, patients die from these. And for some patients, the initial indication that they have a blood clot is actually death. Amongst those that survive, patients can develop heart problems like right ventricular dysfunction or strain because their heart doesn't pump the same, or pulmonary hypertension. At the end of the day, it's very clear that this problem creates downstream problems even amongst the majority of patients who survive. And at the end of the day, it really speaks to the fact that prevention, as opposed to treatment once it occurs, is a critical maneuver for surgeons. Now, it's interesting when I give lots of talks on this topic, people respond and push those talks out there in different ways. I gave a grand rounds at the University of California, San Diego, and I found this on Instagram because this is how they were memeing me and pushing this out. I do think that one thing under blood clots is interesting is that, sure, I have decades of research and clinical experience, but blood clots have thousands of years of evolution. And so we as surgeons are always trying to better understand these are natural phenomena. Your body clots for a reason so that it doesn't bleed to death. And how can we understand and maybe utilize that knowledge to optimize our patients' results? Now, I've been thinking about this a long time. And for this talk, Terry, I had to go way back into the archives because I thought this would be fun. This is the very first talk that I ever gave on blood clots, and it was from 2006. And, you know, I looked through the slides and a lot has changed about blood clots and our knowledge. Certainly a lot has changed about me. I was very much younger, wearing a borrowed suit jacket in this picture, and actually wearing the tie I wore on plastic surgery interviews. It's great.
This is the best before and after of you, right?
Oh, there we go, right? You want to see a before and after. Well, here's another before. So Ed Wilkins is a plastic surgeon still at the University of Michigan, and he was probably one of the initial catalysts for me to get involved in this field of research. And Ed and I have done lots of work together over the last 15 years. One of the first things that we did was this study looking at rates of blood clots in flap-based breast reconstruction. Now, admittedly, a lot of these were pedicle trams because these were data from like 2005. Right. Pedicle trams, some latissimus flaps, showing a rate of about 1 patient in 50. And when we talk later about tightness of fascial closure, you'll understand why that number is probably a little bit elevated. We actually gave this talk, and I guess as a sidebar, plastic surgeons doing blood clot research was not at the time considered the norm. And this is a great example. I gave this talk at a national meeting, American Venous Forum, actually, of vascular surgeons. And so that they understood what belly-based breast reconstruction was, I put this film strip in the bottom corner so they understood what we were talking about. This was a great talk, and it actually won the best talk of the meeting. But I was really surprised to see the initial response, which was the talk was actually censored by the hotel because they found the images too graphic because there were breast and breast reconstruction involved. Yeah. And yet we persevered, and we still managed to win best talk. And more importantly, open the eyes of other surgeons that, wow, blood clots in plastic surgery can be a problem. Yeah. So you want to talk about a before and after? There's my before and there's my after. This is me with Arash Momeni, whose data I showed, and this was a year or two ago.
Great
Um,
surgeon. I just saw him in Miami this year.
well, fantastic. Good.
Yes,
Arash is a good friend.
he is.
I think for patients, I wanna conceptualize the talk today with this, thinking about different opportunities at which clot risk can be identified, potentially modified, risk reduced, but unfortunately risk never completely eliminated. And you'll see me come back to this as a sort of landmark slide during the talk.
Well, this
In the
is great. I think this will be a great tool for patients too.
Absolutely.
So,
Absolutely.
yeah.
So from the preoperative setting, right, this is a discussion that I start having with people at our first meeting. So this is not something I start thinking about in the pre-op area. It's something that I start thinking about at our initial history and physical exam. You will hear me talk a lot about individualized VTE risk stratification, a patient-centric approach as opposed to putting people in buckets of saying you're having this surgery, taking people in their own individual bucket and saying you are you. What is your risk? Here's an example of why individualized risk stratification is appropriate in surgical patients. I'm going to show you a picture and I'm going to tell you there are 23 people in this picture. 2 of them are going to have a clot within a year. You might say, wow, in a group of 23, that's a pretty high number, 9%. Let's put them all on aspirin. And then you're going to look at that picture and you're going to say, wow, I can tell. I know which 2 people are at risk. So why would I give everyone this intervention? Why wouldn't I target it? Now, this is a pretty clear thing, but blood clot risk is not something that you can see. So we have to be a little bit more thoughtful. Now, this is something called the 2005 Caprini score. The Caprini score is the most widely utilized and well-validated VTE risk prediction tool. It creates an aggregate score based on patient-centric risk factors. And in plastic surgery patients, that score, that number, is actually correlated with a percentage-based risk for clots. Joe Caprini is a friend, and this is a picture of us from more than 10 years ago now. And Joe, who is now a retired vascular surgeon, has literally made it his life's work to improve patient-centric VTE risk stratification. This is something that is actively used in not only the breast cancer population, but also the plastic surgery population. These are data from the VTEP study that I'll talk about in a bit, which showed that amongst the overall plastic surgery inpatient population, this score can be used to identify a 15-fold variation in risk. And these are actionable numbers because I, as a surgeon, am going to treat someone very differently, knowing that the risk for clots is 0.6% or 11%. This is also something used in breast reconstruction. This is actually a paper, hasn't even been published yet, just came out of the Cleveland Clinic. I had to call Dr. Rafi Gerlin just to get a copy of this. But the Caprini score has actually just been validated specifically in the DIEP breast reconstruction population. Again, showing that amongst all patients having DIEP, there is this 10-fold or greater risk for clots. And again, as a surgeon, this is actionable information because I'm going to treat you differently knowing which end of the spectrum you're on. This is also why this concept of individualized risk stratification, it's not only our national organizations, it's national patient safety organizations, the American College of Chest Physicians, the entire Thrombosis Canada. You have all of these major organizations advocating for a patient-centric approach. So that's something the surgeon will do. What can you as a patient do? Well, Joe Caprini has been very thoughtful about this question too, and he and I are both huge advocates of knowing your own risk. His own website, CapriniRiskScore.org, has a patient-directed portal where you are actually able to go on, answer questions about your own circumstances, your own family history, print that out, and bring it to your consultation. It's not, you can't calculate your own Caprini score, but at least you can start identifying those risk factors for yourself. For us, we have information like this incorporated into our screening paperwork that no one likes completing, but looking for multiple opportunities to identify those risk factors so that we can modify them. And we'll talk about that now. What a great transition. Risk modification. So the reason that I do this at my preoperative, or not at my pre-op visit, but at my first consultation with someone, is because some of these risk factors are potentially modifiable. And taking a thoughtful and in advance approach, you may have time to change some of these risk factors and thereby decrease someone's risk. Here's one example relevant to the breast reconstruction patient is tamoxifen. Tamoxifen in other studies has been correlated with a higher risk for blood clots. if you are used to looking at meta-analysis data, you look at this and you say, well, there's 5 studies that are pooled here. All 5 studies show the same thing, a non-statistically significant risk from tamoxifen. And this study actually showed that there was no difference in tamoxifen or not. And yet, this is a letter that I got from a patient that I was recruiting for a different research study. And she said, hey, I'm sorry I haven't gotten back to you for several months. You can read this. It's literally in her own handwriting. But I'm in the hospital again for blood clots related to tamoxifen.
Oh.
So there's the patient perception too. So I'm always talking with folks about tamoxifen. I've interfaced with a lot of surgical oncologists saying, listen, is there a downside to taking someone off of a 5-year medicine for 3 weeks before and 3 weeks after surgery? And so in general, I'm holding tamoxifen for my patients because it can take their risk from here to here.
Yeah.
In the operating room, and from the patient perspective, these are things that you would be discussing with your surgeon in advance. Obviously, in the operating room, the patient, lose the opportunity to have that input, but your surgeon is making these decisions for you. But preemptively discussing them is certainly possible.
Yeah.
Now, mastectomies and tissue expanders can't be done under a non-general anesthetic. DEEPs can't be done under a non-general anesthetic. But for my patients having revision work, if I'm doing breast revisions, if I'm doing nipple reconstruction, I will often provide the opportunity to do that under a MAC IV sedation type anesthetic. And the reason for that is that general anesthesia is known to put patients at higher risk for blood clots in the legs or lungs. In fact, there's a very strong recommendation from the AAPS, and they said when possible, and that's important, when possible, consideration should be given to a MAC or other forms of non-general anesthetic because
Can
it
you
can
just,
make safe.
and then, yeah, can you just briefly kind of give us a description of MAC for those that are the patients that are watching?
And so with general anesthetic generally involves a breathing tube and often in longer operations will involve paralysis. I showed pictures of the deep veins earlier, and you understand patients now seeing those pictures, the deep veins are sandwiched between muscles. In your calves, right? I am standing up and down on my calves right now and going in and out of the screen. But when I fire my calf muscles, the calf muscles physically propel the blood up and they prevent the blood from pooling. If you have paralysis, chemical paralysis during your surgery, the muscles don't work and the veins can dilate and fill with blood. As opposed to non-general anesthetics, right? IV sedation, like colonoscopy or Twilight with local anesthetic. I can make nipples and I can do many breast revisions under that IV sedation and local, which still allows your muscles to keep that tone.
Gotcha. Thank you.
Intermittent pneumatic compression. So I just talked about how the calf muscles normally work, right? To physically propel that blood up and out of your legs. When your muscles can't do that, we can do that for you. So these are something called intermittent pneumatic compression or sequential compression devices. They squeeze sequentially. So they squeeze from low to high, and they will, in the operating room, redo what the calf muscles normally do and physically propel that blood up and out of your legs.
I'm smiling. They look very familiar.
Yes, you can minimize but not eliminate risk for clots. These are more meta-analysis data of something like 30 trials in surgical patients clearly showing that use of sequential compression devices decreases risk for clots. And so in any patient having a general anesthetic, these should be used.
Yeah.
And in fact, there's another recommendation, a very strong recommendation from the AAPS about their use. Now, OR time, this is relevant, especially when we start talking about revision work. For some patients, even thinking about mastectomy tissue expanders versus DIEP, there's a several-hour difference in the operation length. In revision work, combining operations for a longer operation, more convenient for the patient. But as you'll see, there's a straight line relationship between time in the operating room and clots. John Kim is a plastic surgeon at Northwestern. He did this wonderful study that I always come back to, looking at 1.4 million surgical cases, not only plastics, but surgery as a whole, showing that no matter what surgical subspecialty you are part of, there is essentially a straight line relationship between time spent in the operating room and risk for clots. This is not me advocating not to do long operations. I do long operations all the time, but it is something for patients to be aware of, that time spent in the operating room does correlate with risk, and operative efficiency would certainly be a question there. Another picture of Arash, who has looked at the intraoperative abdominal wall tightening. And there's a few papers that show this in tummy tuck. In tummy tuck, for those of you who don't know, oftentimes we will find six-pack muscles that are not straight up and down. They're split in the midline. And so those six-pack muscles are tightened they are tightened to each other. That's called plication. Now, plication is great for the abdominal contour. Plication does take everything that's in your abdomen and force it into a smaller space. And so we know as surgeons that that will increase the pressure inside your abdomen. And by extension, when the intra-abdominal pressure goes up, blood can have a harder time getting out of the veins in your legs. This is something that Arash showed using ultrasound of patients having DIEP surgery. What he showed is that when they did ultrasounds of the CFV, which is the common femoral vein, they showed that the common femoral vein diameter got bigger during the operation and after the operation. And the reason for that, it wasn't fluid hydration because the internal jugular vein didn't do that. And that's the light gray line. The reason for that was that the higher pressure inside the abdomen puts a back pressure on the veins. And so this plication is probably why patients who have autologous reconstruction are at higher risk. Now, why would you plicate, right? Well, there's a lot of folks that talk about high def DIEP surgery. And I don't know if this is high def or not, but this is one of my patients. I just saw her back recently. She has had DIEP breast reconstruction on both sides. And I always take a very thoughtful approach to closing the abdominal donor site because I want a wonderful looking abdomen, just like I want to create wonderful looking breast reconstruction. This woman hasn't had any revisions. She has an abdomen that, if anything, is improved from her pre-op. Honestly, I don't feel like you can get results like this unless you plicate. So respecting the abdomen as a donor site, but also something that not just to say, it's the donor site, we want it to look good.
Yep.
There's also a functional component to this. This is another one of my patients. What's highlighted in yellow is the intra-abdominal contents, your intestines and the fat around your intestines. And then you can see on the right side, her six-pack muscles have a 3.5 centimeter gap between them. This is her on the left before weight loss alone and after weight loss. And so this is an excellent example of when you have an intra-abdominal space that's full of fat, and that fat can bulge forward through a gap in the six-pack muscles. Just weight loss alone can notably improve the appearance of your abdomen. We did this. She's a delayed reconstruction patient. There was no time sensitivity. And you can see then her abdominal result from the side after DIEP with plication or tightening. Again, respecting the abdomen as a donor site and recognizing that there is a role for plication to make someone's abdomen look on par with the breast that you're creating. Thinking about after surgery, compression stockings. This is actually something relevant if you're flying to your surgery, if you are doing a destination reconstruction, or if you are flying home from your surgery, or even around the time of recovery. I'm a huge fan of compression stockings. Full disclosure, I'm actually wearing them right now during this talk because I wear them every day to work, both clinic and the operating room. And in fact, the JOPST, I'm a JOPST, I was a previous JOPST award winner from that American Venous Forum, which actually allowed me to bring some of the plastics data that you're seeing and presented to the European vascular meeting, the European Venous Forum. That first talk, one that I gave, was in 2010, and this is my wife, Mandy, showing off the compression stockings that I made/asked her to wear on our flight because we were traveling to a meeting in Belgium and then spending some time in France. Why?
Very fashionable.
Oh, yeah, they're very fashionable. And she threw a fit on the way home because I happened to be wearing shorts. So I wore them with shorts on the way home. That was not a good fashion. I will not do that again. But it is interesting that some very industrious researchers in the early 2000s, they actually rolled an ultrasound study into LAX. And they found people who were about to fly to Asia or to Australia, New Zealand, and they scanned their legs. No one had a clot. They scanned them again when they landed and found that 4.5% of people develop an asymptomatic clot during that flight. And in a subsequent study, they randomized people and said, we're going to scan you. You were going to scan and put compression stockings on. And they showed that they could cut that risk to 0.25% by having people wear compression stocks. So if you're flying to or from surgery, this is a pretty innocuous intervention that is not going to hurt you and absolutely seems like it will probably help. I think it's worth noting that this is pretty deep into the talk, and it's the first mention that we make of anticoagulation. In my own opinion, blood clot prevention is not a binary decision of, am I going to give you a blood thinner or am I not? You can see that there are multiple non-pharmacologic means that you can use to identify risk, to minimize risk, but full disclosure, probably never eliminate risk. Blood thinners are one part of that, but they are not everything. I think that it's good talking about, and you see on here enoxaparin. Enoxaparin is a blood thinner. And a lot of the work on blood thinners and plastic surgery has been done specifically with that drug called enoxaparin. About 13 or 14 years ago now, organized plastic surgery identified risk for blood clots as a major concern of its members and of patients having surgery with its members. And they put together this VTEPS consortium. This was a consortium with Regents Hospital in Minneapolis, Pittsburgh, Southwestern in Texas, and the University of Michigan, where I was in training, and Ed Wilkins and I headed up the Michigan component of this study. Over a several-year period, we were able to look back into the medical records of all those sites and find patients who had inpatient plastic surgery procedures and received no blood thinners after surgery. And then moving forward, we got about 50 surgeons to agree to a uniform practice of routine administration of post-operative blood thinners for their patients. We stratified those data by Caprini score, and you can see that for lower risk patients, those with scores of 3 to 4 or 5 to 6, you really don't see much of a difference between patients who received that blood thinner and patients who did not. The real value or the real clinical impact in reducing symptomatic blood clots came in higher risk patients, those with Caprini scores of 7 to 8 or greater than 8. You can see that for those higher risk patients, routine administration of a post-operative blood thinner at a prophylactic dose can cut your risk about in half, not to zero, but in half of where its baseline would be. And this graph also serves as a reminder about the role of risk modification, right? If you have risk factors that can be taken away before surgery, if you can bring yourself to a lower Caprini group, that can also impact your risk in a good way. This is not only data that's been shown once, it's been independently confirmed that plastic surgery patients with Caprini scores of 7 to 8 or higher rate are at higher risk for clots than some and benefit from blood thinners. And so clinical trials data do support that chemical anticoagulation at prophylactic dose specific to that Caprini 7 or higher population. For many patients, you're admitted after your breast reconstruction, and there's always the question of post-discharge, right? In the hospital, the nurses will give this medicine to you, but at home, patients can self-administer this medicine. There are data in general surgery that show for patients with like major intra-abdominal surgery for abdominal and pelvic cancer that asymptomatic clots can be prevented by after discharge blood thinners. In plastic surgery, that has not played out to my best view of the data. Here's a study looking at extended duration or after discharge blood thinners specific to microvascular breast reconstruction, showing no difference in rates of clots. Another out of New York Presbyterian, again, showing that a blanket application, right, providing post-discharge anticoagulants to all patients just because they had surgery is not warranted. And again, maybe the unspoken thing in that statement is that a patient-centric consideration may be warranted, but we just don't have those data yet.
Okay.
That is an absolute whirlwind, thinking about how best to prepare patients for that consultation. And I completely acknowledge having this conversation with multiple women every week that breast cancer diagnosis can be overwhelming, that thinking of surgical diagnoses can be overwhelming. And to add into that discussion, gosh, now I need to ask my surgeon about my own risk for blood clots. Thinking preemptively, understanding you as a patient, that there are multiple opportunities in your preoperative workup, in your operation, and also in the after operation, before discharge, and even after discharge timeline, where you can identify, where you can modify, you can reduce, but unfortunately never eliminate your risk of blood clots. And from the patient-focused perspective, right, the best advice that I as a surgeon can give you is to show up as prepared as possible. Joe Caprini, Joe does not make any, there is no financial gain for Joe from this site, certainly none from me. This is all about helping patients to advocate for themselves. And so understanding, thinking about your own risks in advance and showing up to your surgeon visit ready to discuss this is probably the best way that you as patients can advocate for yourself. I'm happy to talk. Certainly, Terry, if you have questions, certainly if folks watching this have questions, reach out to me by any means. If you're interested in general in breast reconstruction, following my own page on Instagram. If you're interested in blood clots, following on Instagram. I try to be open and honest, and people call me all the time, and I do my very best to answer those questions. So with that, Terry, let me turn it back over to you. And what questions do you have based on that talk?
So I was making some notes here, and if I were going to sum it up for patients, I think the most valuable thing that I took out of this is talk to your surgeon about your risk score. Ask about that Caprini scale. That's something new to me that I learned this morning. And that individual risk analysis, going back to knowing your risk, talk to your doctor about that because it is very specific. There are higher risk factors, higher BMI and things that you talked about.
Yeah.
And I do encourage the listeners, the beauty of these YouTube interviews, Dr. Pannucci, is that they can stop a midstream and go, okay, what was he talking about there? I love the charts that you showed. Yes. And also, like you said, if you have any questions, I do monitor my educational channel and we do get comments on there. So I will promise you that if I can't answer the questions that patients may, perhaps ask on the channel, I'll reach out to you and see if we can get those answered. So
happy to do so. Yeah.
Yes. This has been very valuable and I truly appreciate the information today and just having you on too.
Great. Well, an absolute pleasure. I always look for opportunities to educate and especially with breast cancer patients to empower with information. And so it's a wonderful opportunity to help breast cancer patients understand the patient safety aspect of surgical treatment of breast cancer and breast reconstruction.
Yeah. Well, that's the mission of the foundation, is to empower and educate. So we appreciate your time today. And again, thank you for joining us today, Dr. Christopher Pannucci, who is out of Spokane, Washington with Plastic Surgery Northwest. Thanks for joining us today.
Thank you.
Uh-huh.